Good morning to all my colleagues for joining us at the breakfast at UMHealth today. And I'm Claire from the Department of Social and Preventive Medicine. It is my pleasure to introduce you our second speaker of the day, Professor Dr. Noran Hairi. Noran is a fellow colleague and a very close friend in our department. She is best known for her work on the epidemiology of aging, and she has a particular interest on the abuse of older people, sarcopenia, and frailty. In addition, she has also made a significant contribution to the study of NCDs, in particular such as hypertension and diabetes, leveraging data from the National Health Morbidity Survey and the National Diabetes Registry. So today, Nora will share her insights on the transformative role of machine learning in the field of public health, with her talk titled The Rise of the Machines in Public Health. She will discuss how these all data-driven approaches such as the unsupervised and supervised learning method can be used to generate predictive insights using various data sources. This talk will be based on a case study applying machine learning methods to predict type 2 diabetes complication using the Malaysian National Diabetes Registry and the national mortality data. Please join me in welcoming Professor Dr. Noran Hairi. Over to you, Noran.
So I'll start. Thank you so much for the introduction, and thank you for the opportunity, Breakfast at Health. Today we'll be talking a bit about rise of the machines in public health and epidemiology. And similar with what we heard just now, half an hour ago, immunotherapy being the next wave for cancer treatment. Similarly, I think this is something new that is coming, or it is already with us today. And I see similarities in the talk that I'm going to say, or I'm going to share with everyone, with what Dr. Balraj said here half an hour ago. So what I plan to do is basically just touch a little bit about the concepts, simple concepts of machine learning. Think of it like, when we learn about systematic review or meta-analysis, there are certain terms and certain concepts that we kind of have to know. Mainly not to do systematic review, but sometimes just to read papers on systematic review. So things like search strategy, we need to know what Boolean operators mean, or looking at study quality, what does the ROB or risk of bias tools are, publication bias, and then we know things like funnel plots. Or moving on to meta-analysis, we need to know what heterogeneity is or I-square is, and of course, the famous forest plot. So similarly with that, the idea here is to introduce to everyone what machine learning is, some of the basic key concepts. So it's really machine learning 101. Nothing to do with Skynet or John Connor or Sarah Connor. As you can see, those who are in my era, we used to watch Terminator 3, and one of the title of Terminator was actually Rise of the Machines, which I borrowed for the talk today. So I'll be talking a little bit about the introduction, key concepts like I mentioned, and using a case study that myself and Prof. Claire, both of us were working using the large data sets of the National Diabetes Registry, and wanted to look at, one of the objectives was to look at machine learning predictive model for type 2 diabetes complications. So I'll start. So basically, the question is why now, right? Again, like what Dr. Balraj mentioned just now, in the field of immunotherapy or in the space of immunotherapy, it has been 30 years, is it 30 years or something like that, the idea was there, and now is what things are happening. So similarly with that, machine and computer, as you can see, this was published in the New England Journal of Medicine, and look at the date. It was actually published before I was born, so in the 1970s, and the idea was, could this machine help us in the field of medicine? But it took a long time, more than 50 years, to where we are right now, and some of the reasons can be attributed to these three factors. So the first one was limited access to large volume of digital healthcare data. And second one would be no powerful processing units to perform this massive computation. Large data sets need really huge performance of computation. And of course, the last one would be the ingredients that was needed for AI algorithm to perform this high level computation wasn't available. So again, when I talk about ingredients, it's a bit like when Poe's father said in Kung Fu Panda, the secret ingredient to my noodle soup was no secret ingredient, something like that. So basically, the ingredient that was needed for the AI algorithm to perform this massive computation wasn't available. And what I mean by AI algorithm, we'll talk a little bit more about the AI algorithm, but basically just think of the AI algorithm like the instruction manual or like a recipe book, right? So the manual can be as simple as, say, for example, you want to do a manual for making peanut butter jelly or a manual for making jam, a sandwich, for example. But it can be as complex as making a fancy cake. So that's what we're talking about, right? So you really need high level performance AI algorithm. So moving on, what is machine learning? So there are a variety of definitions available for machine learning across all the scientific domains. But the definition that was proposed by Mooney et al. In the annual reviews of public health is seriously very broad and very inclusive and really fit for the purpose for the users of public health and epidemiology or even medicine. And it says that an umbrella of term for techniques that fit models, algorithms by adapting to patterns in the data. So the key word here is again the patterns in the data. So that's really, really very important because it's hear me talking about these patterns in the data again, in and out. And sometimes you find that the term AI and machine learning are often used interchangeably, but the word AI is actually more appropriate. And sort of like somebody mentioned, the machine learning is actually used by data science practitioners or practitioners of machine learning, but AI is mainly more often used for marketing purposes or to communicate with the public, right? So back to the definition. To clarify what I mean is that it's helpful for us to think about how we fit models in public health or medicine. Mainly our models are often theory driven. So we have a specific exposure or treatment of interest and specific health outcome. And the goal of our modeling is mainly to model the relationship between this exposure or the treatment to the health outcome. And as a result, what happens is all the other variables that we have are conceptualized as what we call the third variable. So this third variable can actually act as a confounder. I'm sure everyone has heard the term confounder. Do they confuse the ability to estimate the effect of the exposure to the outcome? Again, confounder comes from a French word. Now we're all into Olympics, right? So it comes from a French word. It says to pour, to confound, to confuse the relationship between the exposure and the health outcome. And there are other functions of the third variable. It can also be an effect modifier or an interaction or path or any other collider bias for that matter. So this third variable confuses the relationship between the exposure and the health outcome, right? So again, the traditional approach of what do you call it? This analytical approach that we have in epidemiology or public health is mainly theory driven, hypothesis driven, and the model hypothesis relationship, as we call it. But in contrast, machine learning does not have to have a specific hypothesis in mind. So the goal of machine learning mainly is to uncover patterns, right? Patterns in the data that exist, and to ask the question, can we then infer information about relationship across these features or with the outcome of interest based on what we see on the patterns in the data. So that's a slight difference when you see the approach between the traditional conventional approach in epidemiology when you talk about modeling versus machine learning. And one thing that I would also like to bring across is the difference between hypothesis-driven versus data-driven. So in the early part of COVID-19 pandemic, this was actually released by the NUS, National University of Singapore, to caution healthcare users on AI, right? So there were this, at the start of COVID-19, a lot of scientists was publishing algorithm to predict COVID-19 infections from the lung photos from the X-ray. And one of the results actually turned out that the algorithm was a good algorithm, but this algorithm draw conclusions based on the imprint of the letter R that we see in right lung, for example. And this doesn't mean anything to the clinicians, right? But the idea is because that's the difference between hypothesis driven and data driven. Get the data to drive the results for you. So I think this first concept is very important to understand the difference between the data computing machine learning conventional versus what we have always used in terms of public health or even in medicine. And so much so that Nature came up with this paper, with this paper on steps to avoid overuse and misuse of machine learning in clinical research. For those who are interested, I put up the QR code so you can actually read the paper. Right? So the first concept that I'd like to introduce, there are multiple types of machine learning, and I think the easiest one for us to comprehend would be these two different concepts between the supervised versus the unsupervised learning of machine learning, right? So in supervised machine learning, here what we aim to do is we're trying to learn the patterns that predict the outcome of interest. So what we have is a number of observations. We've got our data, and we've got a number of variables or number of features, as terminology in machine learning and terminology in public health, epidemiology, or medicine are slightly different, so you can get a bit confused with that. So we call these as variables, we call it as features. And you've got an outcome, or again, we call it the outcome, they call it the target variable, okay? So basically, we're trying to predict the outcome of interest. Say, for example, I put an example as death. So it can be hospitalization, it can be complications. The ones that, the example that I'm going to use later on would be complications of diabetes mellitus, which also includes death. So what is the pattern of features, or what is the pattern of these variables that best predict whether someone is hospitalized or not, or whether someone will get complications or not, right? So the algorithm learn not just the patterns, but how these patterns then predict the target variable in the data set, and use that information to make new predictions in the new data set where the values of the outcome are unknown. So there are two parts here. Learning the algorithm, or learning about the patterns that you see in the data, and then trying to use that in a new data sets where you don't know. So the other machine learning approach, besides the supervised, or the opposite, I can't say the opposite, but the other one would be the unsupervised machine learning. So in the unsupervised machine learning, you don't necessarily have the target variable or the outcome of interest. So you can see that's the one in the left side where you have the cluster instead of the death as an outcome, right? So the outcome of interest is not there. So what machine learning does, or what we're trying to do here, is basically to identify patterns within this data on the exposure or the treatment or the characteristics. And among our observation, you do see some patterns. And there are many types of unsupervised machine learning. One example that I think a lot of us can comprehend would be something that's called clustering. So we have a data set and we have a number of observations, and each observation has a number of variables or features. And the goal in clustering is not just to uncover the patterns in the data, but also to group these patterns within a certain cluster. So from the output, a clustering algorithm is assigned to a certain cluster, because you can see that all individuals which are similar will have cluster 1, and those who are, that have similar features would be in cluster 2, and so on and so forth, right? So both these methods are data-driven approaches, and they both use patterns in the data to generate information. So this is just the difference between the supervised versus the unsupervised machine learning. So basically, you can see a lot of papers in medicine or in public health. We kind of use supervised machine learning because it makes a little bit more sense, right? So you learn the pattern to predict the outcome of interest, and then once this algorithm has learned this pattern, then you use that in a different data set where the values of the outcome of interest are unknown, right? As compared to the unsupervised machine learning. And I'd like to bring to also share with you, there's this very interesting TED talk by Eric Topol that talks about whether AI can catch what the doctors miss. And it's so interesting that there are a lot of papers right now using machine learning, supervised machine learning approach, and even to predict things like Parkinson's disease by using retina for checkups, for example. And this was published in Neurology in 2023, in Lancet Digital Health 2022. From the retina checkup, you can actually predict Alzheimer's disease, for example. And he himself is a cardiologist, so he says there are a lot of work done on ECG to look at to use machine learning, supervised machine learning method, and they've shown some promising results where you can actually predict diabetes or pre-diabetes just by using machine learning approach without even before the disease comes in, right? So for our example, this is the work that we did. So we used the Malaysian National Diabetes Registry and the national mortality data mainly for the outcome. Work that I did, I'm doing with Claire and a group of students as well. And one of the objectives is actually to look at, to develop a predictive model to predict the type 2 diabetes complications in Malaysia using a machine learning approach. One of the things that we realize is the data source is extremely important whenever you do this machine learning work or large data sets, right? And because the research question actually wants us to look at longitudinal data, so we need to form a cohort data set. The thing about the National Diabetes Registry is the objectives are, as I put up, to enable tracking of glycemic control, to compare comparisons over time. But one of the things that we realize in the NDR, or the National Diabetes Registry, is that the information on the patients mainly collected from diabetes that are managed in the Ministry of Health clinics, but this can be representative because we realize that almost close to 60-70% of diabetes patients in Malaysia actually go to Ministry of Health clinics to get their treatment. But the thing about the NDR is that it consists of two components, right? It has the patient registry and it also has the clinical audit data set. The patient registry is basically the base registry where all diabetes mellitus patients in the Ministry of Health captured clinical kesihatan will be in. Now, the clinical audit data set is actually a randomly sample of type 2 diabetes mellitus patients from the patient registry and who are on follow-up at the MOH clinic. Now, not all, it would have been really good if you can have all those in the patient registry be part of the clinical audit data sets that they do yearly, right? But unfortunately, due to certain constraints, they only randomly sample type 2 diabetes patients from this patient registry. So we could, to get a longitudinal or cohort manner, what we need to do is actually to get at least a patient who have had two clinical audits done within their follow-up period. So that's one of the things that we realize in Malaysia. We've got a lot of large data set, but somehow or other our large data sets are mainly cross-sectional in nature. So we've got to find ways that we can do some form of data linkage and make it into a cohort data set. The good thing about the NDR, or the National Diabetes Registry, is that the data quality is there and it's monitored under the National Quality Assurance Program. And they've got really good workshops done for the officers who are in this program, where to ensure data accuracy, a very stringent clinical audit work process, and these are all accredited. But one of the things that I must still say is that some of the clinics are still using paper-based form to capture this information. So that's really tough, a lot of work, right? So the first thing that we did is we need to have a formation of the master cohort. And basically this is how it looks like. So we've got clinical, like I said, we've got the registry data set, and out of the registry data set, a random sample of some patients would be collected for the clinical audit for the year. So you might be sampled this year, but the next time you'll be sampled 5 years down the line. So only if you have had 2 samples or 2 data sets, then you'll be in part of this cohort that we did. So patient who was audited at least twice throughout this follow-up period will be part of the longitudinal data set. We tried this and it worked really well. We actually tried this with one state, the Negeri Sembilan. There was some work done I did with Prof. Moy, and now we've moved on to looking at the region, southern region part of Malaysia to form this master cohort. So moving on to back to machine learning. So basically the work that we did is on supervised machine learning, because after we formed the cohort or the data set, we then link it another data harmonization, data linkage process with the JPN, Jabatan Pendaftaran Negara, where we have the death outcomes, right? So birth and death are legally, you need to register them, so you can get this information from the JPN, Jabatan Pendaftaran Negara. So we use the machine learning, supervised machine learning concept. So the second concept that I'd like to share is actually what we call as the data partitioning, or the learn and test. So in machine learning, we use patterns in the data to help predict outcome. And while we are in the process of learning, we have this outcome of interest, so we can actually check whether this is correct, right? And one of the purpose of data partitioning is we learn these patterns and then we help make predictions and then we test them. And mainly in this data partitioning concept, we split or we partition data into what we call the training data sets and the testing data sets. And often the training data sets is bigger than the testing data set because you want the bulk of your data for training or learning your model. And then within training, we learn the patterns and we try to predict the outcome of interest. So generally, you see 70-30, 75-25. We use 80-20 in the work that we did, right? So once we have our model from the training data set, then we apply it to the testing data set. So once we do that, you can obtain predictions and compare to the truth that you get. So this comparison, we do accuracy, sensitivity, specificity. But just understand that there's this thing called data partitioning, which is important in machine learning, the second concept of knowing the supervised and unsupervised. And you've got the learn and the test data set, right? So the other reason why you do data partitioning is to avoid this thing called overfitting, right? And you generally use a cross-validation of K4. You will see this K4 words. It's basically a resampling procedure, and the reason is mainly the idea is to use all parts of the data set that we have for both training and testing, right? And then you create a model that works better in the unseen data. So K4 basically refers to how many partitions you are making in the data, right? In cross-validation, in this example, is we split it into 5 folds, for example. So basically, what we have is, remember, the 80% training data set and then the 20% testing data set. So you train on 4, 1, 2, 3, 4, and then you test on 5. And then the next round, you train on 1, 2, 3, 5, and then you test on 4. And you can see how it works, right? So the idea is, again, to avoid overfitting, another key concept I'll introduce later. So data partitioning has 2 functions. One is for training the model and testing, and then the other one is moving slightly above. You use this thing called the cross-validation. The idea is, again, to avoid overfitting, right? So the advantage of this method is exactly that every single data points that we have is in a test set once, and then it gets to be trained at one point in time. So it's because the idea is that the data or the training data is very important and it's very, very precious, right? So the third concept is algorithm. I've introduced in the first slide what basically algorithm is. Algorithm is basically what you call the step-by-step procedure that the machine uses to learn the final model, right? And there are a lot of algorithm out there. You'll hear things like random forest, decision trees, LGBM, neural networks, and all these different algorithms actually have their own strengths and weaknesses. And as many questions that will come, which one to choose. Again, it really depends on your research question. But one way that is very helpful to decide which algorithm you want to use is to think about it in terms of flexibility and interpretability, right? And it's quite common in machine learning that you use more than one what do you call it, more than one algorithm. So flexibility basically just says how well the algorithm handle complexity in data. I think we're quite familiar with things like logistic regression, for example. So this algorithm is actually quite not as flexible as compared to the other algorithm that you see that I put up here. The other concept is what we call as interpretability. That is how well are you able to understand what the model makes, the decision that they make, right? Because you need to understand, right? You can't just leave it to the machine to generate the model, but you must need to have some form of understanding. And generally, the algorithms that are least flexible are most interpretable. Logistic regression, for example, and those then the other way generally, right? So that's basically a general concept. And so this is the work that we did, right? So our model building strategy is after we split our data. Like I said just now, data splitting is important. So we've got the clean data set and a testing data set. And then we then move on to using 7 machine learning algorithms. So these are the ones that we tried, and how we compare the performance. We use the ROC curve or the ROC curve, right? So the other concept that I like to talk about or introduce is something called tuning. And now this is slightly different from what we regularly use in public health or medicine data. We don't really use tuning so much. Maybe it's easier to understand tuning is, say for example, you're playing a guitar, right? So you need to fine tune the musical instrument. So you would turn the knobs that you get in the guitar to get the perfect pitch. In machine learning, you can do this, right? So the researcher actually can adjust some of the settings in machine. So a lot of algorithms are data driven, but you also have user control hyperparameters that we call it, and to form this tuning. The last concept is what we call as overfitting. I think the idea of overfitting is it's easier to understand. I mean, it makes a lot of sense. What you want is the model to learn the training data, but not too well that it learns every single thing. Because the ultimate goal is to use this model for an unseen data, the data that you don't know, right? So overfitting is when the model learns so well in the training data, including everything, the noise, and fails to generalize to the new data set, as compared to underfitting, which is totally opposite. So you want a Goldilocks approach that's just nice. So it's a balanced model. Okay. So just a little bit about some of the grand challenges that we face in machine learning in public health. I had an opportunity to listen to Prof. Ng's lecture last Friday, and he talks about some of the challenges of machine learning in radiology. And I think similar challenges. One is, of course, data quality. Really need good data quality, data representativeness, because this really matters. And of course, the integration with basic epidemiology. You need to understand the data, things like the variables, things like that I just mentioned just now. Right? I mentioned it, some terms and definitions are different, so we need to learn their terms so that we're talking the same thing. And just to wrap up, I think I do have 1 more minute. This is a good article, User's Guide to Machine Literature, because this is coming. And I've seen many papers on machine learning, similarly with what happens during systematic review and meta-analysis a few years ago. So this is coming. So I think all of us need to at least know some form of key concepts: the supervised versus unsupervised, data partitioning, algorithm, tuning, overfitting, some of these concepts to understand at least what these articles are talking about. So with that, I thank you. Over back to you, Beth.
Thank you very much, Noran, for an interesting session explaining very complex machine learning concepts in a very simple and understandable way. And let me check and see whether there's any question for you. There's one question. Is there any initiative that incorporate lab test data with the epidemiology data into ML development? For instance, the case study that we have presented, is there any biomarker apart from blood test result? I think this one is from, the question is from Selvi, I think. Yeah, Dr. Selvi.
Thanks, Selvi, for the question. Unfortunately, one of the things that we are restricted is what is there in the NDR. So NDR collects the normal, blood investigative result. Doesn't go beyond that, but I would think this is something that's not impossible. I think some of these information we might have. Like I said, one of the things about coming up or forming the cohort data set alone is the first part of it. So we kind of need to be able to be a bit more creative in trying to link some of these data. So if you have those data and you can see the overview or the helicopter view where you can source out the data, this can be done. But in the work that we did, no, we did not. We didn't use any biomarkers data. But it would be lovely to use that.
Okay, the second question and probably the last question in view of time would be, well, I think this is from Dr. Kwong. While your data is obtained from the Malaysian population, do you think the algorithm actually can apply to other countries as well?
This is interesting. Yeah, I do agree. We use the data based on Malaysian populations. So my feeling would be, I mean, if you look at the literature, similar populations that have similar, demographics profile as what we have might be able to be, the model can be used. But this is something, this is just a hypothesis again. It's something that we can, test this hypothesis. One good way would be establish a relationship with neighboring countries and see whether the model actually works. Like what I said, our work was mainly on the southern region, but we also did tests and to see whether the model actually works with an external validation. And we managed to get two states, basically Sabah and Selangor, to see whether our model works, and it does. It does work. Of course, the RC UC curve results actually reduces a bit, which is common in this kind of work, but it can be done. So I think that's a good question, and maybe if we can have some linkage with our neighboring countries, this would be something that we can work on and see how good these models are. Thank you for the questions.
Okay. Okay, thank you, Noran. This is about 9:05 already. So on behalf of the Faculty of Medicine, thank you for all your participation and engaging questions. And I would like to thank both speakers for your time and contribution. And that would conclude our session for today. Thank you very much.
Have a good day, everyone. Bye-bye.
Okay, bye-bye.